Welcome to LINNC 2024. I am Miriam Vicente from Argentina. I am here with Dr. Adam Arthur, the principal investigator of the STEM trial. What can you tell us about this study?
Chronic subdural hematoma, or non-acute subdural hematoma, is a disease that mostly affects older patients where fluid collects on the inside of the skull but the outside of the brain. This is an undertreated cause of loss of function in older patients and prevents them from living their lives. The World Health Organization has identified it as a sentinel health event, and for thousands of years we've been treating this simply by draining these collections of fluid by drilling holes in the skull. The STEM study is the first study to look at embolizing the branches of the middle meningeal artery to both reduce the need for drilling holes in the skull and also to reduce the chance that it would recur after surgical drainage.
You think that the embolized medial meningeal artery is as a unique treatment or as an adjunctive treatment?
I think both.
Both.
I think there will always be patients who need surgical drainage, but I think that there's early evidence that suggests that some of the patients that previously had to have invasive surgery may be able to avoid it with this new therapy.
Did you have many adverse effects during the embolization?
No, the embolization procedure is very safe. In the data that have been presented from the STEM study, 310 patients randomized in the study that I led with Dr. David Fiorella, and then also in a similar study that's a little bit different using Onyx called Embolize that's led by Jared Knopfman and Jason Davies. So very good evidence that it's a safe treatment.
Okay. I saw inside the room you show a case, a beautiful case of a woman who definitely cured for her subdural hematoma. And how many times for the discharge of the patient be in the ICU during the 3 weeks or she discharged?
No. That woman came in falling to one side, cognitively slowed, with real symptoms, bad headache, and actually in her case, she improved within hours in terms of symptoms. She was in the ICU after the treatment. She went home on the second day, and the CT at 3 weeks was as an outpatient in clinic, and she was really asymptomatic and back to living her life and doing all the things she wanted to do.
Did you do any CTs in the meantime, or
no?
In
her case, there was one immediately after the treatment, and then the first one was at 3 weeks. But in the STEM study, we followed all the patients out to 6 months. So we have more data on her as well as the other patients.
The first control is clinical. If you see, it's only clinical the first weeks, and then you do the CT.
No, within the study we did define CT whether there were clinical differences or not. But of course, the most important difference is clinical differences.
And there are many trials right now, such as Embolize and Magic, and you show us many. What do you think are the difference between these trials? The material, the endpoints? What can you say about the other trials?
Yes, as you say, what we're going to see over the next couple of years is a huge amount of new evidence with different materials and different endpoints and different inclusion criteria in terms of patient selection. This is an explosive new development within the field of neurointervention and within medicine overall. So first, probably in this year, 2024, we'll see the first couple of randomized trial publications. I think Embolize will be out with their surgical group first. I think that's going to be in the New England Journal of Medicine. And then probably in 2025 or 2026, there will be a Hermes-like analysis that combines the data from all the trials. So really, we're going to have a large amount of clinical science that will help guide decisions for patients and physicians.
Do you think we can use these techniques for other pathologies as epidural hematomas or clinical pathologies as migraines and chronic headaches?
It's exciting to think about that. I'm not sure that it's going to be very effective for epidural hematoma, since most of those are traumatic
yes.
and quite thick blood that requires drainage. But but maybe that reduces recurrence of epidural hematomas. And then I'm very interested in what we can do for migraine. Migraine affects, in my country, in the United States, about 55 to 60 million people a year. And it's almost always women, and you know we do a much worse job taking care of women than we do men overall. So I think largely within neurointervention, we're going to have new treatments for cancers, we're going to have new treatments for subdural, for headaches, so it's a very exciting time to be within this field.
Anything else you want to tell us about this treatment?
Yes, I think one of the things that's exciting about this treatment is that it's so much more prevalent that we're going to be able to know more about how it affects patients. So we spend a lot of time at LINNC 2024 talking about aneurysms and AVMs and strokes. But within this disease, we're going to have patient-reported outcomes that tells us about how they feel about their lives, and we're going to have neuropsychological outcomes that tells us more about, in depth, how they're able to function, and we're going to have outcomes on length of stay in the ICU and how much the disease costs healthcare systems. And these kind of data, I think, are really important to show the impact of neurointervention.
I think there are a lot of pathologies to come to our treatment by endovascular. I think there are more and more pathologies we can treat in this way.
You are absolutely right.
Okay, thank you very much.
Thanks so much.